Dr. Darshan Shah. Sir is a well-known senior radiologist at Star Imaging with 15 years of experience, specializing in GI and head and neck imaging. He is highly skilled in MRI Defecography, and MRI fistula studies with a special interest in body imaging. I request to Dr. Darshan Shah, please come on the dais.
Thank you so much. I'm extremely grateful for giving this opportunity and be here amongst the clinicians. Get always like these interactions because I get a lot to learn. So, based on what Samrat had said to me, there is a lot of apprehension which is involved in understanding a defecogram or even interpreting what the radiologist is trying to say, which is very obvious, and you'll come to know why the reason it is happening. So, as a part of this talk, I like to focus on the outline, what basically is an MR defecogram, indications, why the patients come to a radiology department, and what is the disease prevalence. The technique, it may not be very relevant to this population, but I'll still just like to brief on what exactly is done and how it is done. Reporting guidelines. Now, sir has already spoken regarding why everything should be guideline based, and hence I'll just try to brief on the protocol which comes to like imaging a patient with the appropriate guidelines and the reporting guidelines as well. We'll see a few cases and then the take home message. Now, can someone help me to get a pointer? So, to begin with, defecogram began in the older era with a conventional X-ray defecogram. The issue being that we are not actually able to see the pelvic diaphragm directly, and we may not be able to evaluate all the three compartments together. But still, it was best tool which was available at that given point of time, and we could evaluate abnormalities in the lumen of the rectum, but not anything which is going outside. What MR gives us as an advantage is two things. It gives us morphology, it gives us function, both coming together. And it is, as the name suggests, it's a dynamic study wherein lot of patient cooperation is required during this particular procedure. I think this is the only procedure in radiology imaging where it's absolutely patient dependent and not radiology or technician dependent. And what it allows us to evaluate at the same time is all the three compartments of the pelvis: the anterior compartment, the middle, and the posterior compartment. Now, the issue with a study like this or a patient like this is that because there is varying degrees of affection of the compartments, the patient could either present to a gynecologist or a urologist or a surgeon. And because of the population to which the patient is going to may not be very well aware with what is happening in the other compartments, it could be possible that the clinician is trying to treat one single compartment. But we need to understand that the pelvic as a diaphragm is a dynamic structure, it's a single structure. And if one compartment is affected, it is quite possible that to some extent there could be affection of the other compartment as well. MR beautifully depicts abnormalities corresponding to all the three compartments. Indications when a patient usually comes to a radiology department, most common could be an obstructed defecation syndrome or something, patient complaining of chronic constipation, or it could be a pelvic organ prolapse coming from a gynecologist or even from a proctologist who says that there is rectal prolapse which is coming there. Sometimes it could be for stress urinary incontinence where the urologist is interested in seeing the hypermobility of the urethra, sometimes for fecal incontinence as well. But you need to understand that the prevalence of the disease which is there in the population, it is 50% of the multiparous women who are beyond the age of 50, they are likely to be affected to some extent in some compartment of the pelvis, which is huge. 50% of patients who are multiparous beyond the age of 50. And so it is quite unfortunately the disease evolves slowly over a period of time, and the patient might think, this is part and parcel of life. and they may not present to the clinician unless and until there is some catastrophic event or patient realizes there is some issue with the urination or something is popping out in the perineum. So, what MR deficogram? There are no contraindications per se to an MR deficogram except for standard contraindications for any other MRI. And basic, the gross issue with the procedure for me as a radiologist is a failed procedure because the patient has not been able to comprehend what exactly is to be done and is unable to provide adequate strain while performing the defecation phase. You might not realize this of a failed procedure, but sometimes when I tell a patient on an ultrasound table to hold his or her breath, they are not able to do so. They don't understand, they don't comprehend what exactly they are supposed to do. When I tell them to hold a breath, they'll keep on breathing in, breathing out, trying to hold a breath either during inhalation or exhalation. So, for an MR defibrillator study to be successful, it is absolutely essential for the patient to comprehend what is to be done. So, study time may be 10 minutes, but me as a radiologist or the technician or the sister or the staff, they have to train the patient to understand what exactly they are supposed to do during the procedure. Now, these are prerequisites, these are standard guidelines which have come up over a period of time through a working group. This working group has involved a whole lot of clinicians, right from urologists to gynecologists to surgeons, colorectal surgeons and radiologists. So they have tried to come up with a comprehensive guideline to how to do a study and how to present it in a reported format. There are some other technical indications which we will skip in interest of time. You can skip this as well. But what I like to mention is what MR deficogram is doing. It is allowing us to evaluate the dynamic nature of the pelvis. Okay? The pelvic diaphragm is somewhat like a thoracic diaphragm. Only thing, it is not moving continuously upwards and downwards, but it's a musculo-tendinous structure and it is bound to move with increased intra-abdominal pressure. It is meant to happen so. And typically the phase or the studies which would involve in an MR deficogram would be a resting phase where the patient is lying down breathing comfortably, a squeeze phase wherein the patient needs to hold the perineum tight and move it upwards towards the pelvis in an attempt to avoid passing stools. The strain phase or the Valsalva phase where the patient is increasing the intra-abdominal pressure but not allowing passage of or not emptying the rectum, and finally the defecation phase. The guideline also mentions the duration for which each phase is to be performed. Typically the squeeze and strain, it would be for the respiratory breath hold duration of the patient. 20 to 25 seconds is what you can expect a population to hold their breath for. But for defecation, they have typically mentioned for a study to say, for me to say that it is not being successful, I need to have at least 3 attempts, wherein each attempt is lasting for up to 50 seconds. The very important guideline which has come up over a period of time is the patient is unable to empty the rectum on table, he or she goes to the washroom, they may require digital splinting of the perineum, empty the rectum and then come back on the table, and I need to repeat the strain and Valsalva phase during that particular point of time to assess what was not seen during defecation, whether it is really there or not. We'll come to see these examples. These are a few guidelines which the patient may probably require some support below the knee so that the knees are elevated. There also has to be support at the foot end of the patient because unless and until that is provided, the strain effort of the patient is going to be inadequate. So this is one particular study, as I mentioned, it is completely patient dependent. So the entire effort while doing, or rather than before the study, has to be towards training the patient of what all the patient has to do in the MR gantry. This training may take up to 50 to 20 minutes for the patient to comprehend what exactly is to be done during the procedure. So on recommendations, what as a radiologist, what the guidelines has been provided, what I need to report during an MR deficogram is the patient position. There are some sensors which are available not in India, wherein the patient can actually, the MR can be done with the patient in the standing or the squatting position. There is another guideline of the amount of rectal jelly which has to be used to distend the rectum. If I initially directly go to 200 to 300 cc of rectal jelly, the rectum gets abnormally distended and the patient may not be able to attempt evacuation of rectum during that particular point of time. So simple guideline is I start with 50-60 cc and ask the patient, are you having a sense or an urge of the distended rectum and a desire to defecate? That is good enough. I need not go directly towards 200 to 250 cc to begin with. Following this, the other important feature that as a radiologist I need to mention is effort of the patient during study, and this would be very well be visualized with movement of the anterior abdominal wall during straining and during defecation. If I'm not able to see movement of that particular anterior abdominal wall during straining and defecation, I'm not able to see movement of the pelvic floor, it basically means that patient is not taking good effort to evacuate the rectum. So these are the standard measurements which have come up over a period of time. Sir has already mentioned to me that they are probably trying to get rid of use of various lines which are there in the pelvis. But as of now, the guidelines do mention that I need to come up with these, and these guidelines are more dynamic. So maybe over a period of time, we may not be required to give all the measurements in the report, and it could probably be more dynamic and just mention what all is going on as a part of the anal canal, the rectum, the movement of the perineum and the pelvic floor. So what I need to mention is different lines. We'll just come to that in the next slide. And the presence or absence of cul-de-sac hernias, presence or absence of abnormal inferior rectal or perineal descent, presence or absence of a rectocele, rectal intussusception, and something which is mentioned is the change in the anorectal angle. The significance of that, I'll just let you know. So the apprehension, I'm just going to end it right away, what these lines and measurements are. It is very simple. PC line, it corresponds to the pubococcygeal line. So basically it's a line which joins the inferior margin of the pubic symphysis to the last coccygeal articulation. It's not the tip of the coccyx, it's the last coccygeal articulation. It basically reflects the position of the pelvic floor when the patient is at rest or even during the dynamic stage. The other is the H line that corresponds to the hiatus line. It's the hiatus of the pelvis which is bound by the puborectalis ligament on either side and posteriorly, and anteriorly by the inferior margin of the pubic symphysis. Then we have the M line. It basically indicates the position of the anorectal junction in relation to the pubococcygeal line. Up to 1 to 2 centimeters, if it's a perpendicular which is drawn from the anorectal junction, which is the junction between the posterior margin of the rectum and the long axis of the anal canal. That's the anorectal angle. And I draw a perpendicular from the point of this angle to the pubococcygeal line, that is termed as the M line. It basically gives an indicator what is the degree of variation of the position of the anorectal junction in relation to the pubococcygeal line during the dynamic MRI Defecogram study. And that's lastly the anorectal angle. I've already mentioned it's an angle between the line drawn along the long axis of the posterior wall of the rectum and the long axis of the anal canal. Now, see, in spite of there being guidelines, there is a lot of variation in the normal anatomical landmarks as well. So sometimes it is possible that the M line or the anorectal junction, it would lie above the pubococcygeal line. But if it lies within 2 centimeters below the pubococcygeal line, it is a normal anatomic variation and we need not bother for it. So what MR Defecogram would help us identify is presence or absence of descent from the anterior, the middle and the posterior compartment, and we would give corresponding descriptions in terms of cystoceles or abnormal vaginal descents or abnormal uterine descents, abnormal anorectal or perineal descents, and presence or absence of any cul-de-sac hernias. Okay, so before coming to what is abnormal while doing an MR Defecogram, let us identify what is normal. Okay, so that's the resting phase, that's the squeeze phase, and the strain and defecation phase performed as a single sequence. So if you see during the resting phase, that's the anorectal angle, the anal canal is closed, the anorectal angle is somewhere close to 90 degrees. What happens during the squeeze phase is that the puborectalis sling is an horizontal obliquely oriented sling. It moves more towards the pubic symphysis, and hence we see there is reduction in the anorectal angle. So the anorectal angle becomes more acute. And what happens during strain and what is expected to happen during strain and defecation phase is that the rectum needs to come more in line with the anal canal. For that to happen, the angle should actually increase than what it was during the resting phase. So it needs to become obtuse. So if this was 90 degrees, the squeeze would be reduced to say varying degrees somewhere between 70 to 60 degrees. And during strain and defecation, what would happen? It would increase beyond 90 degrees going towards 100, 120 or 130 degrees. Unfortunately, we don't know what is normal. So best is to compare it to a patient from the resting phase to the squeeze phase and then towards the strain and defecation phase. So this is just an example. Okay, so this is what is happening during a dynamic phase. What we see, there is inferior displacement of the pelvic floor. There is inferior normal descent of the bladder, the prostate, the uterus if it's a female patient, or a vaginal wall, which is happening because the pelvic floor is a elastic structure. It's not a rigid structure. So increase in the intra-abdominal pressure, you are going to see that descent. What you also see, okay, just look at the movement of the anterior abdominal wall. It basically means that the patient is making a good effort. Sir has already mentioned, while examining, you keep the hand on the anterior abdominal wall. It will give us a good grade of what effort the patient is putting. So we can actually see the movement of the anterior abdominal wall when this is happening. And what other thing is happening is that there is increase in the anorectal angle, which is very essential, because if this angle it increase, the rectum is lying more in line with the anal canal and is more easy for the rectal contents to pass beyond the anal canal. So what happens during dyssynergetic defecation? Okay, so during rest we expect the angle to be somewhere close to 90. It may not necessarily be 90. It could sometimes be 70, it could be 75, it could be 100 as well for patient to patient. What happens during squeeze phase? There is reduction in the anorectal angle because of the pull which is created by the puborectalis sling, and that is what is expected. But if I am getting a paradoxical reduction in the anorectal angle during a strain and defecation phase, that is abnormal. Because in spite of what is expected, I want the puborectalis to relax. I want what is expected is the rectum and the anal canal to come in line. If that is not happening, it is paradoxical, it is abnormal. And this is creating a dyssynergia between opening of the anal canal and the rectum not being in line with the anal canal. So this is normal. During rest, angle is somewhere close to maybe 80 degrees in this patient. During the squeeze phase, there is reduction in the anorectal angle. During strain, there is inferior descent of the pelvis and some increase in the angle. The angle has become more obtuse than what it was during rest and squeeze. And during defecation, you see that the rectum is almost in line with the anal canal, allowing good evacuation of the rectum. So what would be seen as a radiologist, for what I would be seeing is that there is delayed initiation of evacuation because the patient is not able to open the anal canal completely because the puborectalis continues to indent the posterior rectal wall. It results in impaired evacuation. The bolus of contrast which was there in the rectum is not going to flow freely across the anal canal. And paradoxical decrease in the anorectal angle when the patient is straining. We expect the angle to increase during straining and defecation, but that is not what is happening. And then there would be prominent indentation of the puborectalis sling on the posterior wall of the rectum. So this is normal. That's a normal reduction in that's the normal angle. As I mentioned, sometimes it would be 90 degrees, sometimes it would be 100 degrees, would differ from patient to patient. So during this, rest in this particular patient is close to 100 degrees. What happens during squeeze? Because of the indentation pull of the puborectalis, it has got reduced. During strain, there is increase in the anorectal angle. We also see there is a cystocele with the bladder neck going down. But what happens paradoxically in dyssynergetic defecation is that there is this tug on the indentation on the posterior wall of the rectum created by the puborectalis, and then instead of an expected increase in the angle, there is a paradoxical reduction in the angle, and hence the patient is not able to evacuate the rectum. Okay. So depending on at the end of a study or the end of defecation, depending on where the bolus of gel or the ultrasound gel is retained into the rectum, it could also give us some hint to what is going abnormal into the pathology. So that's the pubococcygeal line, PC line, which is drawn from the inferior margin of the pubic symphysis to the last coccygeal articulation. What has happened in this patient during the attempted defecation and straining is the anorectal junction has moved abnormally downwards. Up to 2 centimeters is expected, but it is going much more below and it is increasing, basically indicating that the pelvic floor is much lax going down. See what has happened to the anterior wall of the rectum. It has gone much anterior to the expected anterior wall of the inner canal. So patient is having an anterior rectocele, which are much more frequent than the posterior rectoceles, wherein the posterior wall of the rectum would be bulging posteriorly. That is something what we see as the rectorectal intussusception. So if this is happening, the bolus of the gel is likely to be retained above that intussusception into the proximal third of the rectum. While if I have a pelvic cul-de-sac hernia, what this cul-de-sac hernia does, it comes down and it indents the anterior wall of the distal rectum, and all the jelly, it gets retained more proximally. While in a rectocele, at the end of evacuation, the jelly would be retained into the distal rectum, and we will also be able to see the presence of a rectocele during the dynamic defecation phase. Okay. So just to show you a few examples of what is happening. So this is the resting phase. We see the angle is somewhere close to 80 degrees. During squeeze, good indentation of the puborectalis, and during strain, there is much more abnormal inferior displacement of the anorectal junction. There is inferior displacement of the bladder neck as well. And this is what is happening during the defecation phase. Now the rectum is distended with jelly, but the patient is unable to defecate. Patient is unable to open the inner canal, and the rectal contents are being retained within the rectum. You would also appreciate the patient is making good effort because there is good displacement of the anterior abdominal wall when the patient is attempting to strain. Okay, so as a guideline, when the patient is unable to evacuate the rectum, he or she would be brought outside the MR gantry, would be sent to the toilet, allow them to evacuate the rectum in the vertical setting position, and then we are going to repeat the strain phase. Now see what is happening during the strain phase. Because when the rectum was full, the patient was unable to evacuate, and I could not identify a rectorectal intussusception during that particular point of time. But now if you see, after the patient has come, there is an abnormal rectorectal intussusception, and in fact there is much more abnormal inferior descent of the pelvis, and I'm also seeing probably a peritoniocele which is there sitting in between the uterus and the rectum, which I would have completely missed if I would have not repeated the strain phase after evacuation of the rectum. So this was the defecation phase with the rectum being distended. The patient is unable to evacuate the rectum, while when post-evacuation strain phase, you'll appreciate that the bladder neck is much more lower down. The uterus also has gone much more lower down, and we are actually seeing a rectorectal intussusception during this. So this guideline strongly recommends that we repeat a strain phase if the patient is unable to evacuate the rectum. So this is what we'll be commonly be encountering. That's the resting phase. That's the squeeze phase where you see reduction in the anorectal angle. Then that's the strain phase with abnormal, with a expected, I won't say abnormal unless and until we see it continuing, with inferior descent of the anorectal junction. The patient is unable to evacuate the rectum, and then we repeat the strain phase and see this much more abnormal pelvic floor laxity and descent of the perineum caudally. This is what a report would mention. I have already clarified what PC line. PC line corresponds to the pubococcygeal line, which is drawn from the inferior margin of the pubic symphysis to the last coccygeal articulation. It basically gives us a reference mark for the pelvic floor. The anorectal junction could lie above this or within 2 centimeters inferior to the presence of the PC line. The H line is the hiatus line that we draw from the inferior margin of the pubic symphysis to the anorectal junction. Up to 6 centimeters is considered to be normal, and ultimately is the M line, which is basically a perpendicular which is drawn between the pubococcygeal line to the anorectal junction, and it gives us a reference to what degree the anorectal junction is moving during different phases of a dynamic defecogram study. That's about it. Nothing too complex about it. So coming to take-home message, what we've seen today is it would MR defecogram, if the patient is compliant and understood the procedure, it would allow us to evaluate good anatomic as well as physiological function of the pelvic floor and the other presence or absence of pelvic prolapse, including all the 3 compartments. It may happen that the patient has gone predominantly to a gynecologist to evaluate the uterus, but while doing an MR Defecogram, we would also see that there is some abnormality in the anterior and posterior compartment as well. And patient may require therapeutic management for the same. So it will help us, it is a good guide to distinguish between surgical and non-surgical cases as cases with dysenergetic defecation. It would also may plan or modify the surgical intervention required depending on what degree of prolapse is happening in what compartment, which was initially not picked up during clinical assessment. And this is one particular study which it is completely patient dependent. If the patient is unable to comprehend what is to be done, the study is a failed study. So as a radiologist, it is my responsibility to make the patient understand what exactly is expected out of them in the MR gantry. Patient education and some minimal basic mathematics, which would probably evaporate in the future, would give us a good result in MR Defecogram. And what we are actually seeing patients coming to us may be tip of the iceberg. We never know that this could actually be a big clinical component to it, and many more patients coming to us in the future. Thank you so much.
Thanks, Darshan, for demystifying such a seemingly complex topic. I think the questions are going to be taken